I'm Erin Trish. I'm the Associate Director of the Schaeffer Center. Welcome. We're pleased to have you today for our webinar on the future of value-based payment. So we are pleased to have with us today two excellent panelists. The first is Liz Fowler. Liz is the Executive Vice President for Programs at the Commonwealth Fund. She's had an impressive career spanning the private and public sectors, including as a Senate staffer and positions at HHS and the National Economic Council, as well as at WellPoint, and most recently as the Vice President for Global Health Policy at Johnson & Johnson. She's a member of our advisory board at the Schaeffer Center, and we're pleased to have her with us today. We also have, as part of our conversation today, Paul Ginsburg. Paul is the director of the USC Brookings Schaeffer Initiative for Health Policy, the Leonard D. Schaeffer Chair in Health Policy Studies at the Brookings Institution, and a professor in the Price School of Public Policy and the director of public policy at the USC Schaeffer Center for Health Policy and Economics. So Paul wins the award for having most Schaeffer appearing most times in his title of anyone. And for that, we're very pleased to have him here today. He also has a very impressive career spanning the academic and health policy sectors, including time at CBO and as the president and founding director as the Center for Studying Health Systems Change. He's also currently the vice chair of MedPAC, the agency that advises Congress on Medicare policy, but wanted me to let everyone know that he does not speak for MedPAC today. So great with those introductions. I know that we kind of build this webinar as a discussion of the future of value-based care, but before we dive into that, I wanted to take a moment to step back and talk about the origins of this kind of modern era of value-based payment. And by that, I mean really thinking about the Affordable Care Act, which included a number of provisions that really set things like accountable care organizations and CMMI into motion. So as we think back to the lead up to the ACA, there was really a lot of focus at the time on expanding coverage for the uninsured, but also there was this interest in addressing rising healthcare spending. And really thinking about why as a country we pay so much more for healthcare than other countries do, and really what are we getting in return for that, and what role does our underlying kind of fee-for-service structure of payment play in driving that level of healthcare spending. So Liz, at the time of the kind of passage and enactment and write-up of the ACA, you were serving as the Chief Health Policy Counsel to Max Baucus, who was the chair of the Senate Finance Committee at the time. So you were really on the front lines of the drafting of this legislation. Can you tell us about that experience and really kind of what was the motivation for including these payment arrangements and what led ultimately to these provisions being drafted the way that they were?
Sure, thanks. And thanks, Erin, for inviting me. I really appreciate the opportunity to be here and think so highly of the Schaeffer Center and Paul and his work. So it's an honor to be part of this. So I'd say, to answer your question, there was sort of a convergence of factors that had a very keen interest in moving towards a value-based payment system. First, there was a bipartisan sort of growing interest in trying to find ways of paying for value instead of paying for volume and moving away from fee-for-service. There were bipartisan bills, a lot of hearings and efforts centered around this. Second, I would say there was as much as we think about the Affordable Care Act as a way to expand coverage, and certainly that was the primary goal, there were just as many members of Congress who were worried about growing healthcare costs and growing spending, and who wanted to make sure that ACA wasn't just about coverage, but was also about ways of controlling health spending, and looking towards these value-based payment designs was part of that equation. And then the third factor is the employer community. And I know that doesn't sound like, an obvious answer, but the large employers had been trying to move towards value for a while and finding that they just didn't even have the market share. Even the largest national employers didn't have the market share in a market to be able to make these changes. And so they wanted Medicare to take the lead and lead the way. And so they were some of the biggest proponents, like the Business Roundtable, for example, in pressing us to keep making changes in this direction and including policies, along with wellness. I think that was the other big push. But so I'd say those three factors sort of led to an interest in including these provisions. I'll also say, as we started looking down the road of what should we include in this area, there weren't a lot of solid ideas as we were getting technical input from the Centers for Medicare and Medicaid Services. What could we do? What has been tested? What would work? Instead of there's a lot of ideas that seem sort of maybe more academic and theoretical, but couldn't be translated into policy in a short period of time. The ones that were definitive policies, like the hospital readmissions, value-based care payments to hospitals, the hospital-acquired conditions, those were ones that were mandatory for everyone. ACOs was another idea that was more fully formed, and we had a lot of input from experts like Mark McClellan into those provisions. But then there were a lot of ideas where we weren't sure what would work, and so that's why CMMI was created, the Center for Medicare and Medicaid Innovations. If we just put an amount of money available as seed money to see what might be working, to see what might work, and then test those strategies, and then give the agency the authority to expand a strategy if it was working to the whole population or to all payers or whatever the direction was. So that was sort of the genesis of why the provisions were included and why they were drafted the way they were and why CMMI played such a prominent role.
Interesting.
If I could add something to what Liz said. It's fairly common when a very important piece of legislation is perceived to be moving through, that many other related issues that are bipartisan, not controversial, have been discussed for a while, get added on. And I think the value-based payments probably meets that criterion. And that actually was very good because, with all the polarized partisan reactions over the coverage, the fact that the value-based payment was always on a solid footing, and that really continued from one administration to another.
Interesting. So that's interesting, Liz, to hear you talk about the kind of various coalitions and the role of the employer coalition. I think another, potential important group to think about is the providers, right, who were going to be impacted by this change in terms of their practice. And at the time, Paul, you were working with the Center for Studying Health Systems Change, and which had a longstanding history of running the community tracking study and doing other site visits. So I know, for example, when I go talk to my doctor, just as a patient, but make the mistake of telling them that I'm a health economist, I hear all kinds of viewpoints about kind of, that providers or as physicians, they think they know what's best for their patients and kind of long for a time when they could just practice medicine and not have to worry about all this stuff. But I'm curious if you can provide some perspective about kind of what you heard from physicians and providers and their readiness and their interest in kind of engaging in this direction.
Yeah, well, let me make the distinction between the provider leadership and the provider rank and file. And my sense is that the provider leadership, the American Medical Association, American Hospital Association, leaders of very prominent institutions were very interested in pursuing alternative payments. And even though I think there's a lot of hesitancy among the rank and file for actually doing it, but I think that support by the leadership of providers has been something that's been with us for a long time, and from what I can tell, it has not wavered.
Interesting. Okay. So, Liz, I think now it's been about 10 years since the kind of passage or enactment of the ACA, and we've had a chance to do some research to look at kind of how these programs or how these provisions have worked. Your organization, the Commonwealth Fund, published a nice synthesis of this a couple of months ago, and kind of reached the conclusion that there may have been quality improvements and some kind of mixed effects, but at best the kind of impact in terms of reducing spending has been modest at best. Earlier this week, CMS just announced the results from their kind of newly revised ACO program, the Pathways to Success program, touting the fact that these ACOs generated about $1.2 billion in savings for the Medicare program in 2019, the largest magnitude of savings ever in the program's history. And this has really been lauded as kind of a successful move for this program. But to put that in context, we spend about $400 billion annually on fee-for-service kind of spending through the Parts A and B program. And so I'm wondering if you, Liz, as well as Paul, can kind of touch on, are we actually moving the needle in terms of spending through these programs, and are we making a difference in this transition to value-based care?
Well, thanks for referencing the Commonwealth report. If folks have a chance to go back and look, it came out in April, and it really was a comprehensive synthesis of the evidence for all the different strategies in the Affordable Care Act and what the impact has been, from the mandatory ones to the CMMI demonstrations to, and across both administrations, the Obama administration and the Trump administration. And like you said, I think the evidence is really mixed. Either the savings was really small, or maybe there weren't a lot of savings, but the quality was okay, or maybe the quality improved, but marginally. And in some cases, it just was really hard to say definitively that any of the strategies worked really well to say that this is what we should be doing going forward. Part of that is, I think you have to think that a lot of these were voluntary too. So, it wasn't a mandatory program. It was sort of, providers could pick and choose what direction they wanted to go. So if you get a chance to go back and look at that, that report, I would recommend it. And so I think, like you said, it's great that the report came out about the ACO savings, but I think it is such a small fraction of overall spending. And I think if you look at the challenges facing Medicare going forward, it's not going to be enough to bring the program into, financial balance, which is, I think, the next debate we're going to have. And so I think we had 10 years to sort of experiment around, and now we're going to really hit crunch time. And I don't know that we know what should come next out of the strategies that we have online now. And we can talk about that more, about what direction things ought to go. But you're raising a good question.
Yeah, and just to touch on that, Paul, I know this issue of kind of voluntary provider participation is an issue that you've been thinking a lot about. As Liz noted, this has really been a voluntary program participation to date. It's also the case that in 2019, we saw a reduction in the number of ACO participants. And so I think, I'd like to hear your thoughts on kind of the future directions for this program, and are we ready for a push to make this mandatory?
Yes, that's a good question. I would say that when a program is voluntary, for one thing, it's much more difficult to have confidence in your evaluations of whether it's saving money. Because a lot of it depends on the type of selection. The providers expecting to do well are the ones that participate. And so in a sense, it often exposes the program to risks of losing money, because they're going to pay some providers rewards for things they would have done anyway. So, and I think just all the accommodations to providers to get them to enroll often weakens the tools, often weakens the incentives, and I think reduces the potential for success from at least Medicare's perspective of saving substantial amounts of money. So, you certainly need to do things on a voluntary basis at the beginning when you're working out the models. But I think at this point, in some of the areas, I think bundled payments, I think ACOs, are probably far enough advanced that we can start moving them to mandatory. Now, it's one thing to have a mandatory bundled payment for something that everyone does, like joint replacements. I think with ACOs, it's not so clear as to what an ACO is. And I think there you might have to use something like incentives, such as we're going to pay you more overall if you're in the model, and we pay you less if you're not. So a lot more of you likely will come into the model, and then we get somewhat closer to behavior in a mandatory world.
Interesting. So I think we're going to continue on with this conversation, but I just want to take a moment to note to the audience that we welcome your questions. You can use the Q&A feature at the bottom of the screen as well to send questions to me, and there'll be time to share your questions with our panelists later on in the session. So, coming back to this kind of notion of voluntary or mandatory participation, for example, in the ACO program, right, we've really relied on, that there is no mandatory participation on behalf of the beneficiaries, right? And we're not requiring the beneficiaries make a choice or kind of pre-attribute themselves to a particular set of providers, unlike the choice to join a Medicare Advantage plan. And so I'm curious, as you think about this transition to kind of making or to requiring participation among providers, do you think that we need some type of commitment or pre-commitment on behalf of beneficiaries and patients as well?
Yeah. I think on beneficiaries, I don't think you need a commitment as much as asking them to identify who their primary care physician or clinician is, because that's so important, and it's where the program often falls short of attributing beneficiaries to physicians, especially the healthy beneficiaries that don't have a lot of services. So that if we had a process where patients were, in a sense, brought in a transparent way, brought into, we have this program, it's designed to improve quality and reduce costs. We'd like you, and maybe we will reward you or reward your physician if you can identify who is your regular clinician. And I think that would make a big difference. So in a sense, it still wouldn't be like Medicare Advantage, where enrollees are really committing themselves to the network. And beneficiaries could still go anywhere they want in traditional Medicare, but at least could run the program so much better if we could more accurately link up the beneficiaries with the physician that they tend to use the most.
Well, and just adding a point, because that question did come up back in 2009 as we were thinking about the program. And I think the concern on the beneficiary side would be if you're seeing a provider who has downside risk, whether that might lead to skimping on care, whether that might lead to, not referring to a specialist because there was a financial stake for the provider, the referring physician. But I think the programs as they were envisioned weren't necessarily a lot of downside risk. I mean, a lot of them were mostly upside risk. So for the patients anyways, at least in the early days, there was more upside to being to working with a provider or having a primary care provider who was trying to manage your care better and coordinate your care better. And it seemed like there was less risk for beneficiaries. But as we move into two-sided risk, if we move into requiring patients to be part of, a network or an ACO and not being aware of it, I think, maybe we revisit those questions, although you have to think about how complicated can you make this system. I think one lesson we've also learned from the ACA is just how complicated our system is. And what we learned during COVID is the negative impact of having so much complexity. So I would be a little bit wary about adding even another layer of complexity.
Well, of course, patients already are in ACOs without any decision on their part, just because they have seen an ACO physician. So in a sense, this would just make the attribution much more accurate. And I think if we're worried about patients avoiding providers that are facing downside risk, our ability to actually succeed in this area, I think, is very limited.
So Liz, you kind of touched on our complicated and complex healthcare system. I think another kind of key thing to consider here, we've primarily been talking about the role of Medicare, which is, largely been the genesis of many of these payment reforms on the federal side. But providers treat patients who are covered by all different sources of insurance coverage. And, there's been innovation in this front out of the commercial market as well. There's important differences across these programs, right? We have a federal program on the Medicare side where prices are regulated and that faces a different set of incentives, or we have more market competition on the commercial side. We have seen some kind of spillover effects from some of these federal payment policies. So Alice Chen, who's a professor at the Schaeffer Center, and some of her colleagues have done some work on the joint replacement, the bundled payments for joint replacement through the Medicare fee-for-service program, and they've seen spillover effects in terms of treatment decisions for commercially insured and Medicare Advantage patients, right? And so sometimes you can think about this as the Medicare program, kind of generating positive spillovers to these patients who are insured by other coverage sources. But I think we also need to be, somewhat concerned about to what extent Are providers being faced with too many different incentives? Are they competing incentives? How can we kind of align the direction that we want to push these providers to going, and how do we create a comprehensive payment environment that kind of recognizes that they're treating all these different patients under these different payments arrangements?
Well, and how are we measuring quality and outcomes, which seems to be different across payers? So, I do sympathize with providers who are, having to comply with a lot of different approaches to measurement and what constitutes quality and what constitutes, their payment and the incentives, and keeping all of that straight. It seems to me be better to have more uniformity in how we're measuring outcomes and how we're paying providers.
Yeah, I think there's real potential, and I think many discussions have gone on of bringing private insurers and Medicare officials to the table to talk about, if they can get closer to what each does as far as measuring quality, just to reduce the burden on providers and to make the quality incentives more effective. I think as far as other aspects of it, certainly there's an effect of when Medicare does something, the rest of the market pays attention. If they react that they think it's a good thing, they may copy it. And Medicare can learn from what private insurers are doing too. So I'm hoping that will be a tendency to get the private sector and the public sector more on the same page. I'm not saying that one should decide what everyone does, but I think there's potential to get more closely aligned because they're dealing with the same medical care delivery system.
Yeah, interesting. And I'll just note on that point that there was a letter from CMS to state Medicaid programs earlier this week as well, kind of highlighting this and harmonizing payment incentives across and expanding this to the Medicaid program as well. So seems like there may be more to come on this kind of harmonization front. But one kind of question that this raises is the role that kind of politics may or may not play in federal payment programs, right? And so, I think it's clear that CMS and HHS over the last decade have worked hard to design and implement effective payment policies that are, have the goal of getting more value from the system. But ultimately, when we're talking about a federal program, there's a lot of interested parties, and they're, kind of have a legislative agenda to answer to and an administrative agenda to potentially answer to, and a lot of other interested stakeholders as well. And so I'm wondering what you think, or what your sense is of kind of, this isn't just always about policy, but sometimes about politics too, and what role might that play in the move forward toward value-based purchasing and kind of improving value in our system?
Well, politics always comes into play whenever you're talking about federal health policy, and I know Paul knows that as well. And Paul alluded to the way that these payment systems were designed, and the voluntary nature was based on trade-offs with a lot of the stakeholders. I'd say, even the mandatory policy, the value-based care payments for hospitals, was budget neutral for a reason, and that's because, that's the way that the providers negotiated some of these provisions with members. So I think it's hard to take politics out of it. And I think right now in the middle of COVID, and we've seen, such a decline in provider revenues, it hasn't hit all providers equally in terms of the burdens that they've had and the loss in revenue due to the declines in volume and who's come back and who hasn't. So I think right now it's I think most policymakers are pretty sympathetic to the challenges that providers face right now in the world of COVID. On the other hand, the providers that had invested more heavily in value-based payments and alternative payment models may have done potentially better under COVID than others who stick purely with the fee-for-service approach. And at least some of the providers that we've talked to have said that there was some value in having had sort of the downside and upside risk in play, the incentives for coordinating care and better outcomes. So maybe there's a push in favor of value-based care going forward. and maybe there's more support on the provider side for moving forward. But I'd be interested in Paul's take on that.
I think one variable that's going to determine the role that politics play is the federal deficits. Congress in particular has not been very sensitive to effects, to the very large and really growing deficit. This may change. I think if it does change, you'll see it reflected in not necessarily partisan basis, but maybe how both parties become more interested in, say, moving more boldly in this direction to, in a sense, deal with Medicare's long-term financial problems and the country's in that respect.
Yeah, absolutely. Liz, you touched on COVID, and I think you're absolutely right that COVID's had a huge impact in terms of hit to provider, or a significant reduction in healthcare utilization, which when you're a provider means exactly kind of a reduction in provider revenue. David Wickman, the CEO of United Health Group, earlier this week, actually, as well, it's been a big week in terms of value-based care quotes and discussions, that said that they've actually seen a significant uptick in interest in providers moving toward value-based payment arrangements after kind of seeing the benefit that those arrangements have on protecting them from the kind of declines in utilization and the resulting declines in revenue that they've seen. On the other hand, we've heard some speculation that providers may want to kind of recoup some of the losses or reductions in care moving forward with a kind of rebound from some of these deferred elective procedures, and may not necessarily want to kind of be under the constraints of value-based purchasing arrangements as they're trying to do that. So I'm curious what you guys think will be the kind of net effect on the movement toward value-based interest and participation among providers as a result of these changes.
Yeah, that's a good question, Erin. I see a short-term and a long-term effect of the COVID-19 experience. I think in the short term, you very much have providers that are stressed financially and not willing to take on more risk. On the other hand, in the long run, you've seen changes in delivery, like say the greater use of telehealth, that would never have been tried out as extensively as it was during the pandemic. And many of the changes that providers did just to accommodate severe constraints of the crisis are things that have shown some of the potential of departing further from fee-for-service and using alternative payments. So in a sense, in the long term, I think the experience of COVID-19 has, I think, shown more clearly some of the potential to do things in a different way and a more effective way from both a quality and cost perspective.
Yeah, I think that's a really good answer, Paul. And I think the jury will still be out. And I also think the COVID story is still being written. And at least having calls earlier on, there seemed to be this nervousness about, well, we can't take on that much. But there's also a recognition that fee-for-service really doesn't work when you rely on volume as your main source of revenue. When volume declines so precipitously in such a short period of time, it really puts providers under a huge amount of constraints. And I know there was a question there about primary care providers, and in particular, I think we need to think about what the solutions are for primary care providers, especially ones in smaller practices that probably are, I saw an early statistic that, 1 out of 4 primary care practices were at risk of closing early on. So I think the COVID story is still being written. I think it's almost impossible to predict what direction will go coming out of this, but I think the points Paul made make sense to me.
Absolutely. Okay, we have a lot of great questions coming in from the audience, so I'm going to turn over to some of these. One question, going back to Alan Enthoven, health economists have argued that price transparency and outcomes reporting would allow private payers to identify efficient and inefficient providers. The Trump administration has taken some steps toward increasing price transparency in healthcare markets. do you think this effort will bear fruit and move toward this kind of a market-based efficiency approach?
I'm very skeptical about, and increasingly research is backing this up, that many attempts at price transparency have not been very effective, even in situations like people with large deductibles that have very strong incentives that, you give the consumers better information on provider prices and they don't use it, or they just have very little change in their patterns. To me, the insurers know the prices because they've negotiated with providers. And to me, an insurance network is really a device to use competitive forces by, shaping a network to, reflect both how expensive providers are and their performance. I think a lot of the price transparency initiatives have been, in theory, possibly useful, but they really haven't panned out.
So I guess I would say and we're very interested in the question of transparency at the Commonwealth Fund. I think part of the question is, are you relying on transparency to change patient behavior, or are you relying on transparency to change payer behavior, or make it easier for payers to compare? And I think the notion that somebody's going to shop around for services, the notion that patients will find this information useful and actionable, and translatable, be able to use it and translate it, I think is maybe misplaced. I don't think that that's why you want transparency. But if it helps payers understand what they're paying relative to Medicare or relative to other payers, or I think that can be a useful exercise. And I don't say this that often, but I really appreciate, and I think that what the Trump administration has done in this area has been positive, if for any other reason, to start the debate and have a conversation about it. So I think, we're supportive at the Commonwealth Fund of all payer claims databases. We're supportive of efforts to try to educate employers and other payers as to what they're paying relative to Medicare, as one way of trying to tackle high healthcare prices and high healthcare costs.
One thing I brings to mind is that when Medicare started publishing, provider prices, bill charges in comparison with Medicare, initially I reacted, this information, isn't very relevant to Medicare patients because it has no effect on what the Medicare patient pays and no effect really on what Medicare is paying. But what was fascinating is all the journalists I started to identify cases of what looks like fraud. And I think people started understanding that there's a lot more fraud in medical care than they might have imagined. And I don't know how well it's been followed up, but it was very eye-opening.
Yeah, it's definitely, I hear this referred to as kind of provider shaming by a number of, journalists or others, and that's another kind of goal of some of these initiatives, and giving people the ability to do that. We have a number of other questions. So one is focused on essentially thinking about how we measure the perpetuity of, if we're setting targets. I think this is a controversial, something worth weighing in on for sure. As we think about setting target or payments and benchmarks and things for kind of bundled payments or for ACOs, we have to set some kind of spending metric against which we're judging those providers. And ultimately, if they're effective in doing well at reducing their spending, that kind of, if you're building that savings into future benchmarks, that reduces what those benchmarks might look like, and kind of may create this feedback where providers are, in some sense, almost being penalized for doing a good job of reducing spending early to then have not a lot more to reduce moving forward. So how do we think about kind of setting appropriate benchmarks and encouraging kind of long-term incentives to continue to reward providers for those types of ongoing savings?
Yeah, well, if you're going to revise your benchmarks according to provider behavior under the incentives, that is just self-defeating because you're just diminishing the provider's incentives to do well. And you have to compromise. Maybe that you want to leave benchmark in place for a number of years so that, achievements that providers make, they get a number of years. And, the more you can divorce benchmarks from what a particular provider's spending has been and move them on to, community level benchmarks, that's really the direction to go. And I think CMS has been going in that direction, although there's some other issues on that side, like a greater need to do risk adjustments.
We have another questioner asking about kind of comparisons between the savings that we've seen through Medicare Advantage plans relative to some of these kind of payment demonstration models through the fee-for-service world, and thinking about kind of as we compare, right? There's a number of studies, and obviously risk adjustment's always a challenge in comparing beneficiaries in the Medicare Advantage program relative to those in the traditional Medicare program. But it is certainly the case that we have seen some sizable reductions, some studies that point to sizable reductions in utilization and spending among enrollees in Medicare Advantage plans on much larger orders of magnitude than arguably what we've seen coming out of some of these ACO and other models. So this questioner is asking kind of, have we identified some winning value-based approaches, and what should we attribute to what we see coming out of the Medicare Advantage program, and are there lessons we can learn from that side that may be applied to the fee-for-service side as well?
Well, I think there's not a monolithic single answer to Medicare Advantage. I think there are clearly advantages to patients who are enrolled who may need that extra coordination, where the care is comprehensive, where prescription drugs are part of the whole package and are managed as part of overall care. But I think there are still areas to consider for adjusting payments. I think looking at the quality program, for example, the star rating program, and still some of the gaming that we see. And I think any discussion of Medicare solvency is going to have to open up Medicare Advantage and take a look down that road. And so I don't know that I have a great answer, just that I think there are clear benefits to Medicare Advantage. And I also will say that as we move from fee-for-service towards something resembling partial capitation or full capitation, that was ACOs sit along that continuum. So from medical homes to ACOs to two-sided risk to partial capitation to capitation. I think there's value in looking down that road and managing patients' care better. But I think we have to make sure that we're paying appropriately. We have to address gaming. We have to make sure that the quality metrics and the quality programs are rewarding the right behaviors and the right incentives. So I guess all of that is up for grabs. So I'll let Paul see. Paul may have a better answer
now that he's well illuminated.
Yes.
It's not an inconsistent answer. My sense is that the Medicare Advantage program has been achieving increasing efficiencies in delivering care to the Medicare patients. I attribute a lot of that to the pressure on Medicare Advantage rates that began with the ACA, so that Medicare Advantage rates were way above Medicare on average. Medicare spending for fee-for-service people, and they were attempted to be brought down to be the same. And I think that motivated Medicare Advantage plans to invest a lot more in improving delivery of care. Now, the problem for the federal taxpayers in the Medicare Trust Fund is that those savings have not been captured by the Medicare program at all. I think it's still costing the Medicare program money. Some is going to the beneficiaries. But in a sense, there are, as Liz said, there's a big agenda. For example, this is the only Medicare program that has quality bonuses as opposed to quality incentives that are budget neutral. So in a sense that the quality bonus plan was pretty successful. It got a lot of plans to boost their quality as measured by the STAR system. But in a sense, many, almost all of them are good at it now. Isn't it time to stop rewarding them and in a sense set the bar higher? That for those that have really great quality, they can get extra rewards. But for those that are just okay quality, maybe they should get penalized. It should be the same way we do it for hospitals and other quality incentive programs. And yeah, as Liz said, there's a lot of gaming on the risk adjustments. Although there are some things that are, say, favorable to Medicare Advantage plans. The fact that the significant number of traditional Medicare beneficiaries only have Part A and not Part B, usually because they're still working and getting employer-based coverage. And that, in a sense, holds down the base for Medicare Advantage payments. But overall, I think Medicare continues to be overpaying, even though the Medicare Advantage plans have achieved a
Okay, well, lots of great questions from the audience. Unfortunately, we're not going to have time to get to all of them, but I do want to give one last kind of high-level question and then give you a chance if you have any final thoughts. But we have a bold question coming from the audience is, with all this discussion of value-based payments and purchasing and variation across different types of incentives and providers and payers and whatnot, should we just be headed towards single payer? Is that kind of where we need to go to truly transform our healthcare system? And is that the answer here?
Well, as somebody, my last job was a global role. And the great thing about that job was I got to travel around the world and learn a lot about other countries' healthcare systems and compare them to our own. And I think there's a lot to be said for universal coverage and making sure that everybody has access to affordable coverage. I am not sure that our population, our American culture would do well under a single payer system where there were potentially restraints on the type of care you could get. Or, today, if your doctor tells you you don't need an MRI, in other countries, you might say, okay, that's fine. I don't need an MRI. Here in this country, if you're told you don't need an MRI, but you're pretty sure you looked it up in WebMD and you need an MRI, you just find another provider that's going to give you an MRI. I asked hospital administrators in other countries, what do you do when you run out of your global payments? And the answer I got in several countries was, well, we close our emergency room until the next fiscal year. There are types of constraints that are involved in these systems that I'm not sure that would be tolerated by American patients. On the other hand, we need to do something about 30 million people who don't have coverage. And all of those people, almost twice that are either uninsured or underinsured who can't afford their deductibles. So we need to find solutions. I'm not 100% convinced that going down that road is what we need to do, but I'm glad at least we're talking about having this debate and maybe figuring out a path forward to fix the things that ail us.
I think that we can get to universal coverage based on the an enhanced ACA, using tools such as auto enrollment, more eligibility for Medicaid, et cetera. My concern with single payer is that I think private insurers have done much better at addressing the utilization side. Medicare is much better at addressing the price side. I think there's potential for, applying some of that pricing power to private insurers. But Medicare as a single payer program with, run with a board of directors with 535 members, the members of Congress, I think is very constrained in being bold in addressing costs other than squeezing provider prices.
Absolutely. Well, Liz and Paul, thank you so much. It's been a very interesting discussion, and we really appreciate you participating and sharing your thoughts and expertise with us. And it sounds like there's more work to do, so we should all probably get back to doing that and/or petting the dog.
Right.
Yes. But thank you all, and thank you all for attending.